It is a quite exceptional honour to be awarded the Prince Mahidol Award 2012 for medicine. To now find myself in the company of such previous distinguished laureates is overwhelming. I was born in 1941 in the town of Shrewsbury, close to the Welsh border. My mother had been a nurse before her marriage, and my father was a Church of England priest. He served in the British Army as a chaplain during World War II. His own father, my grandfather Joseph Rawlins, served in the British Army during World War I, but was killed at the Battle of the Somme. My father Jack survived World War II, but died from a heart attack soon after, when I was just 5 years old, so I have only the vaguest memories of him. 10 years after my father died, my mother remarried. My stepfather was a wonderful man and a dedicated physician, and it was a result of his influence, together with the memory of my father's early death, that made me decide to become a doctor too. My applications to study medicine at both Oxford and Cambridge were rejected, so I went to the same hospital, St Thomas's Hospital in London, where my mother had trained as a nurse. I graduated in medicine in 1965 and spent the next 7 years training in general internal medicine and in clinical pharmacology. In 1973, I was appointed to the newly established Ruth and Lionel Jacobson Professorship of Clinical Pharmacology at the University of Newcastle upon Tyne in northeast England. I spent 33 years in Newcastle, combining the roles of a general physician, looking after patients with a wide range of acute and chronic conditions, conducting research into the effects of medicines, and teaching undergraduate and postgraduate medical students. But my professional career has had 3 overlapping phases. The first was as an investigator in Newcastle, developing evidence to support the safe and effective use of medicines. The second phase was as a policymaker, using evidence to actively promote the safe and effective use of medicines. And the third, most recent phase at NICE has been devoted to helping others using evidence to support not only the effective and cost-effective use of medicines, but also the use of other diagnostic and therapeutic interventions in the promotion of the public's health. In the first phase of my career, as a clinical pharmacologist, I devoted my research activities to better understand the reasons why people vary so widely in their response to medicines. This involved exploring, in both healthy volunteers and in patients, the mechanisms by which medicines cause therapeutic as well as unwanted effects. I was especially interested in why elderly people are less able to tolerate medicines at doses that rarely produce unwanted effects in younger people. I also undertook a range of clinical trials to assess the effectiveness of interventions in the treatment of both children and adults, and at the same time I used a variety of observational techniques to investigate the adverse, the unwanted effects of medicines. The second phase of my professional career began in the 1980s when I was appointed to be a member of the Committee on Safety of Medicines. This was the national advisory body that advised the government on whether new medicines should be allowed on the market and whether existing medicines should be withdrawn from the market because of unacceptable adverse effects. The committee no longer exists because decisions about the licensing of medicines are now taken at a European level. At that time, though, these decisions were taken nationally, and the convention was that although the committee technically only advised health ministers, ministers always took the committee's advice, and if there was any trouble, the committee's chairman was expected to go onto radio and television to explain things to the medical profession and the public. In the early 1990s, I became chairman of the committee, and I had to learn how to perform on radio and television the hard way. In my role as a member and ultimately chairman of the Committee on Safety of Medicines, I needed to learn how to use evidence to assess the risks and benefits that were associated with particular products. And I and fellow members of the committee made decisions with major consequences for the health of the public. During this period, I was also using the expertise I'd acquired in another way, as chairman of the UK's Advisory Council on the Misuse of Drugs. This body was and remains responsible for advising the government of the risks to both individuals and society of substances like cannabis and crack cocaine, This required an evaluation of evidence of another sort, observational rather than experimental. Towards the end of the 1990s, the British government announced that a new organisation, the National Institute for Clinical Excellence, or NICE as it quickly became known, was to be created, and I was asked to become its first chairman. In this role, and in the third phase of my professional career, I have been involved in helping others to use evidence for the public good. Setting up a new organisation was challenging. There were no staff, no premises, and very little money. But we went ahead, appointed a superb chief executive, now Sir Andrew Dillon, found some modest office accommodation in central London, and went ahead. In the beginning we had two roles. First, to examine the clinical and cost effectiveness of new, mainly pharmaceutical interventions, and recommended whether they should be used in our National Health Service. And second, to develop clinical guidelines, again for staff working in the National Health Service, and again based on clinical and cost effectiveness. At the time NICE was established, the notion that the National Health Service should take account of cost was to some an anathema. Nevertheless, over the years, my clinical colleagues and the public have come to accept that cost effectiveness is an essential component of priority setting for any healthcare system. We all globally have limited resources available for healthcare, and it is incumbent on us to use the money in the wisest possible way. For if we spend a lot of money on a few patients, other patients with other conditions will be denied cost-effective care. How have we managed to bring people with us? There have, I believe, been 6 essential components. First, our assessment of the available evidence has been extremely robust. All NICE guidance is based on a full and systematic review of the available technical, scientific and clinical evidence. This, if it is to be done properly, cannot be rushed. It is often arduous. It requires considerable expertise, and it is time-consuming. Nevertheless, without ensuring that our scrutiny of all the available evidence is thorough, we would never enjoy the confidence of the clinical professions in the conclusions we reach and the advice we give. Second, we try to be inclusive and make sure that all those with a legitimate interest in the guidance we're developing have an opportunity to contribute. This includes, of course, specialist clinicians, nurses as well as doctors, manufacturers of drugs, devices and diagnostic agents, and of course patients and the organisations that represent them. Indeed, when we are developing clinical guidelines, we always include 2 patients in the development group. Third, we try to be transparent with the evidence that has been used in the development of the particular piece of guidance and with the processes we adopt, as well as the reasons for the decisions we make. Fourthly, the conclusions reached by the Institute and the guidance we provide for the National Health Service is developed not by NICE's own staff, but by the independent members of our advisory committees. They're volunteers drawn from the National Health Service and from the staff of British universities. They need to possess expertise in evaluating evidence and making scientific value judgments about the information that is provided to them. Fifthly, we always produce guidance in draft form before publishing our final conclusions. This is what is sometimes described as contestability. It provides our stakeholders with the opportunity to challenge the conclusions that have been reached before they become firm policy. And we and our advisory bodies listen very carefully to these comments. Consequently, our advisory committees are required to confirm that they have scrutinised stakeholders' comments and explain their reasons if they reject them. Finally, as I've already stated, we at NICE recognise that in making decisions based on evidence, judgments also have to be made. And these fall into 2 types: some scientific judgments and social value judgments. Sometimes, those with little experience of using evidence to inform decision making assume that the evidence itself is sufficient for drawing conclusions. It is not. The scientific evidence is never perfect. The clinical studies, individually and collectively, always have some question marks around them. The members of our advisory committees must therefore take account of how robust the evidence really is, the extent to which it reflects what is likely to happen in real-world use, and so on. In other words, they have to make scientific judgments. But in making decisions about the use of interventions for the public health, there are also social values have to be considered. These relate to social sciences rather than basic or clinical sciences. They take account of the ethical principles, preferences, culture and aspirations that should underpin the nature and extent of the care provided by a healthcare system. These social values include issues like whether special priority should be given to children and adolescents, or whether healthcare systems should be prepared to pay premium prices to treat very rare diseases. The members of our advisory bodies have no greater legitimacy to make these social value judgments than the public, and so at NICE we have created a Citizens' Council of ordinary people, the public, to inform our social values. The discipline of analysing and evaluating the evidence required to inform decision making has become known as health technology assessment. In Thailand, the Health International Technology Assessment Programme, HITAP, is an exemplary health technology assessment agency. It evaluates the totality of the available evidence, thereby ensuring that all Thais have access to good quality, affordable healthcare in the context of Thailand's commitment to universal coverage. I pay special tribute to the work of HITAP because it has been able to show in a resource-constrained environment that access to cost-effective care, irrespective of the ability to pay, is possible. NICE's continuing work with HITAP, allowing us to share methods and processes with each other, is a fine example of international collaboration between two health countries both committed to universal healthcare coverage. In accepting the 2012 Prince Mahidol Award for Medicine, I am conscious that it is testimony to the work of my colleagues at NICE International with agencies around the world. But no agency is more special to us than HITAP in Bangkok. Once again, thank you for your kindness and generosity.